This video is an introduction to the basics of mammography. First, we will discuss what is mammography. A mammogram is an imaging study that uses X-rays to evaluate the breast for breast cancer. There are two types of mammograms that we perform. One is in the screening setting and the other is in the diagnostic setting. In general, screening mammograms are performed in all women every 1 to 2 years after the age of 40 with the goal of identifying a breast cancer. Screening mammography recommendations are a current hot topic, both in the medical community as well as the media, with varying recommendations related to the age of initiating and concluding the screening imaging as well as the frequency to perform it. Diagnostic mammography is when the patient has additional mammographic images above and beyond the routine views that are performed. One scenario is when an abnormality is seen on the screening study and the patient returns for additional views to further evaluate that finding. Another scenario is when the patient has a symptom related to their breast, such as a lump, pain, or nipple discharge. There are 4 standard views performed in every mammogram, with 2 views of each breast. This image here and this image here are 2 images of the right breast, and this image here and this image here are 2 views of the left breast. As you can see, rights and lefts are reversed, as is the case with other imaging studies. The name of the image comes from the location and the direction of the X-ray beam. For example, a CC view stands for cranial caudal, which means that the X-ray extends from the cranial or the superior aspect of the breast and extends through the breast towards the patient's feet. This is an image that shows how the CC view is performed. The breast is placed in compression and the X-ray beam extends from above the breast through the breast to hit the image receptor below. What you get are these 2 images here. The upper aspect of both of these images represent the outer portion of the breast, and the lower aspect of both of these images represent the inner aspect of the breast. So just to restate, this is the outer left breast, this is the outer right breast, this is the inner right breast, and this is the inner left breast. The MLO view stands for medial lateral oblique, which is the direction that the X-ray beam travels when the image is acquired. In the MLO projection, the breast is placed in compression at a 45-degree angle, and the X-ray beam travels from the medial aspect of the breast, which is here, through to the lateral aspect of the breast. The result are these 2 images over here, where this is the superior aspect of the breast, and this is the inferior aspect of the breast. So just to restate, this is the left upper breast, the left lower breast, the right upper breast, and the right lower breast. We use these images to help us triangulate where a finding is. For example, if we see a mass here and here in the left breast, we can say that the mass is in the upper inner left breast. Alternatively, if we see calcifications here and here in the right breast, we can say that the calcifications are in the lower outer right breast. Now we'll review patient positioning. Correct positioning of the breast within the mammo unit is very important, and there are certain requirements of all studies. The breast needs to be pulled out far enough from the chest wall to make sure that all of the breast is being imaged. The way that we evaluate this is by making sure that we see the pectoralis muscle on the MLO view, which is here, all the way to the level of the mid-nipple line. And we also want to see the pectoralis muscle on the CC view. And the pectoralis is representing the chest wall, so we know we have all of the breast tissue anterior or superficial to that. Along these lines, the distance from the nipple to the chest wall, this measurement here, should not differ between the MLO and the CC view by more than 1 centimeter. If they do, then it suggests that one of the images has captured more of the breast tissue than the other image, and that we might be missing some of the breast on one of those pictures. Next, the nipple should be in profile on at least one of these pictures to make sure that we've adequately imaged the retroareolar region and haven't missed this area or confused the nipple with a potential underlying mass. The nipple should also be angled slightly up on the MLO view to make sure that the entire breast is being lifted and that you're able to evaluate this lower inferior portion of the breast. And lastly, each MLO image should adequately capture this portion here, which is referred to as the inframammary fold. And this again is to make sure that you've sufficiently captured the inferior and the posterior aspect of the breast. Now that we've acquired our technically adequate study, we have to interpret the imaging. And the first thing that we evaluate is what the tissue density is. This refers to the percentage of glandular tissue relative to breast fat within the breast. Glandular tissue is the portion of the breast that has ducts and lobules and produces milk if a woman were to be lactating. It typically is white, whereas breast fat is typically gray on a mammogram. So there's a spectrum of proportions that we typically see. This image on the left represents what we call a predominantly fatty breast, where there really is no white glandular tissue within this breast that might potentially hide a breast cancer. You can see that breast is predominantly gray/black. The next level is something that we call scattered fibroglandular densities here, and you can see that there are these little white areas within it that represent little areas of fibroglandular tissue. And then we get into the next category, which is called heterogeneously dense breast tissue, and you can see that there's far more white glandular tissue here scattered throughout the breast. And then the last category is dense, which is here, where the breast is predominantly that dense fibroglandular tissue. We categorize it because we know that as a woman's breast has increasing fibroglandular densities, there's an increasing chance that we'll miss an underlying breast cancer. The reason for that is that glandular tissue is white and breast cancer is white, and so the fibroglandular tissue can mask an underlying malignancy. When interpreting the mammogram, we're looking predominantly at three things: masses, calcifications, and architectural distortion. A mass is a space-occupying lesion that we can see on two of the projections, both the CC and the MLO view. An example of a mass is this here. You can see I'm going to circle it. This lesion here in the lower left breast, and this lesion here in the central left breast. This is one and the same, and it's a breast mass. When you see a finding on two views, but it doesn't have as discrete borders as you would find with a mass, we call it a focal asymmetry. And when you only see a finding on one view, we call it an asymmetry alone. When looking at a mammogram, we also look for calcifications. This is an example of a woman with very dense breast tissue. You can see this very white fibroglandular tissue in all four views. However, within here, the upper central to inner right breast, we see these little white dots that seem to be extending from the chest wall towards the nipple. And these are called calcifications. These are calcium deposits that lie within the breast. And calcification within the breast can happen for a number of different reasons that are both benign and malignant. We use the imaging characterization of the calcifications to help us decide how worried we are about these calcifications potentially being a cancer. These are schematics of the breast, courtesy of radiology assistant, to help you better understand where calcifications and masses form within the breast. So here on the right, you have a schematic of the breast that shows ducts that branch into smaller ducts and ductules. And here at the end, they branch into these little bud-like structures called acini. And it's within these acini that milk is formed, which then extends through the ducts towards the nipple when a woman is lactating. This unit here is called the terminal duct lobular unit. And this is the location where a predominant number of breast cancers form. It is also a common location for calcifications to develop. Calcifications can form within the acini, as in this example here. This is an example of benign calcifications called milk of calcium. Fluid within the acini may be present even when a woman is not lactating, and this fluid can calcify. These calcifications layer within the fluid and can form a teacup configuration, as you see here. This feature tells us with certainty that these are not cancer and are, in fact, benign calcifications. To the right, here, is an example of a different type of calcifications, and these are associated with malignancy. These calcifications are linear and branching within the small terminal ductules and are classic for cancer. So ultimately, we use the imaging features that we see to help us determine the likelihood that these findings are benign or malignant. And lastly, we look for architectural distortion, which is really a secondary sign that there might be a breast cancer within the breast, and all that we're seeing in is the pulling in of the tissues around the breast cancer. Here's an example in the right central upper breast, where there's almost like a sunburst pulling in appearance here and here. And this is typically what we see, and it's a very subtle finding. When we see it, we have to make sure that there's an underlying explanation for this area of pulling in. Does this represent a new breast cancer with associated changes of the surrounding breast tissue, or could this be related to a person's prior history of surgery or trauma to the breast in this location? For this reason, we often put scar markers over the area where a person has had prior breast cancer surgery so that we know that any architectural distortion that we see in this location is related to that intervention. We don't typically put markers for surgeries for benign disease, but there is an indication for this in the tech notes that we have. Lastly, we are going to talk about how we report these imaging studies, and we use something called the Breast Imaging Reporting and Data System, otherwise known as BI-RADS, to guide how we dictate our reports and how we code each exam. The BI-RADS provides recommended words to use to describe a finding that we see on mammography, so that everybody who's reading our reports understands whether we're worried or not worried about a finding. For example, if we see a mass that does not look like cancer and is round or circumscribed and doesn't have vascularity to it, we use these words according to the BI-RADS lexicon to guide our dictation. As compared to if we see a spiculated irregular mass, we use these words to suggest that this might be a cancer. The BI-RADS also provides a coding scheme that is required for each report that we dictate. The coding system is as follows. If we have a finding that we think we need additional imaging in order to better evaluate that finding, we will code this study as a BI-RADS 0, which means that the assessment is incomplete. Once we state this, this means we either need to bring the patient back for additional pictures, or we need to get prior imaging in order to compare the current study to old exams. This happens most frequently at the time of the screening mammogram interpretation. The next BI-RADS code is a BI-RADS 1, and we use this code when there is absolutely no finding on the mammogram study. We use BI-RADS code of 2 when we see a finding, but we know with certainty that it's not cancer. And this might be, for example, an intramammary lymph node, which really is just a lymph node that's living in the breast, but not cancerous or not cancerous looking. BI-RADS 3 is when we see a finding and we're not really sure if it's cancer, but we think it's probably not cancer. In fact, we think with 98% certainty that it's not a cancer. And in cases like this, we typically recommend a short interval follow-up ranging from 1 month to 6 months. When we code something as a BI-RADS 4, we are saying that we are worried about this finding and we think it needs to be biopsied. Within the BI-RADS 4 category, we have 3 subcategories, BI-RADS 4A, BI-RADS 4B, and BI-RADS 4C, which indicate how worried we are about that finding. A BI-RADS 4C means that we are very concerned that the finding is a cancer. A BI-RADS 5 is one step up, which, by definition, the finding is highly suggestive of malignancy. The recommendation for BI-RADS 5 lesions is often biopsy as well. However, the patient may go to surgical excision or have additional imaging performed at that time. A BI-RADS 6 lesion, or rather we code reports as BI-RADS 6 when the patient has a recent diagnosis of cancer that has yet to be treated. And so we're saying that there is a biopsy-proven malignancy present in the breast at the current time. Again, every report that we dictate has a code assigned to it, and we are therefore telling everybody who reads our reports how worried we are about the findings that we see and what our recommendation is what we think should happen next. So in conclusion, we have reviewed what a mammogram is, what the different types of mammograms are, what the 4 routine views are of a mammogram, how to properly position for a mammogram, what the basics are for image interpretation, and how we use the BI-RADS code. This information should serve as a foundation for the remaining rotation that you have through the breast service. Feel free to ask any of us any questions as you have them. So thank you for your attention.